Yeah.
Muted.
All right.
All right.
We're a minute late, but I think the public will forgive us. Guess we need to get this meeting going today. Do we have a motion to start the meeting?
So moved.
Second? Everyone in favor? All right. Are you doing the introductions today?
Yes. We have no guests or members of the public today.
All right, first thing we need to do is approve today's agenda items.
I would like to make note that there is a typo on today's agenda.
Okay,
Under 2.5.1, it says fiscal year 23. That should actually be fiscal year 22.
all right, we have one noted change in 2.5.1, changing the year from 23 to 22. Anybody else have? We have a motion to approve the agenda.
Second.
Second. All those in favor? Any questions, changes, notes on the August meeting minutes? Nothing? Do we have a motion to approve the August meeting minutes?
So moved.
And a second?
Second.
All right, all those in favor?
Aye.
We went through the bills schedule, we sent it to them, so everybody has a copy. Are there any questions or comments about the bill schedule?
I assume the Walmart item,
Where are you at, Bill?
page 2, 5,235.49 Walmart. That was probably fair related, or?
No, I believe that probably the Help Me Grow stuff.
It's for the diapers and wipes, and the state reimbursed us for those.
Okay.
Incentives for the program.
Any other comments or questions? Well, the Van County Nursing Services, is there some collaboration going on there?
Yes, and I can let Shannon go ahead and elaborate on that.
So that is the Get Vaccinated Ohio grant, and the way the state sets it up is that they still allow other counties to apply for the grant, but if their maximum amount they're allowed to bring in is less than $30,000 for the year, then they have to partner with another agency. So we did this in the past with Putnam County before they were able to raise theirs, so Van Wert reached out to us and asked if we partner with them, so we're the partnering agency for them. So basically, they send their reports to us, we send it to the state, and then we invoice them back for the work that they did.
Any other questions or comments on the August bill schedule? Do we have a motion to approve the August bill schedule?
Second.
And all those in favor?
Aye.
So 2.4, we need to recognize the following revenue that's going to fall in fiscal year 12/31/22. We have 2.41 integrated naloxone project in the amount of $17,200. Do we have a motion to approve?
So moved.
Second. All those in favor of recognizing this revenue?
Aye.
2.4.2 enhanced operations project in the amount of $30,000. Do we have a motion to approve?
Second.
All right, and all those in favor of recognizing this revenue?
Aye.
Aye.
Okay, moving on to 2.5, we're going to approve a revenue decrease for the following fiscal year 12/31/22. It's Get Vaccinated Ohio 2.5.1. And as noted, that's actually 22 project and a 23 project in the amount of $14,204. Do we have a motion?
So moved.
Second.
Second.
And all those in favor of this revenue decrease approval?
Aye.
Aye. 2.6, Board of Health rescind variance request made on 5/20 by Mr. Pelfrey of Big Lick Township. 2.6.1, Mr. Pelfrey requested board approval to allow 2 mobile homes to connect to a new NPDES type of sewage treatment system at 6194-6200 County Road 23, Alveda. And he wants to, we're going to rescind the variance request.
I can go ahead and elaborate on that.
All right.
So back in May, he had come with the request of wanting to hook 2 mobile homes to one off-lot discharging sewage system, which is the NPDES. After some more work with a contractor and with our office and just some things that he's wanting to do in his personal life with that property, we were able to do some moving around, and he was actually able to install 2 separate sewage systems. So 6194 has its own system now, and 6200 has its own system now.
Which is in compliance and doesn't need a variance.
Correct. This is actually a better option.
Okay.
Yep. So because we had issued that variance, we need to resend it. So when we get audited for this through the sewage program with the state.
And motion to approve.
So moved.
Second.
All those in favor?
Aye.
Aye. I think Lindsay, you're starting off with staff reports 3.1.
Yes, so our August financial report here, everybody should have a copy of it. Looking at the 7-year balance sheet. Green would be yelling at me. As you can tell, we're kind of maintaining steady with where we've been in the last couple years here. Through our expenses and through our revenue. No red flags is sticking out to us at this point at the leadership level anyhow. We're continuing to monitor all of that, especially as we come into this last quarter of the year. We're always paying extra special attention then. And then on the other side, we have our revenue trends. We're sitting currently with 1.7 million in cash, a little over, which is a little better than where we started the year because we started at 1.6. So I think we're staying on trend with that. Any questions? And then the other thing underneath the financial report, as mentioned, we have just completed, or we had completed our fiscal audit for 21. I'm not sure if the state auditor had sent out messaging to all of you. I know as being part of that team, I think Cream was pretty happy with how that ended up. I know there was the one deficiency that requires a response, and that was actually an error on the part of the accounting firm that we hired to do our yearly financial statement. I reached out to them and spoke to them about the issue. They totally had the documentation to be able to see how they had actually put the information in the wrong line item. So they were able to easily identify the error, and they actually sent us a message decreasing next year's statement when they do it. They give us like a $350 discount for next year's. So unfortunately, we had that, but at least we know the issue and where the error lies. The other thing that's a small is 2 little errors in our fiscal policy book. We need to update our cash management policy and the and our procurement policy. The state auditor's office has good guidelines on what these should look like. So Chelsea and I are reviewing that, and that policy book's going to get updated. Actually, I think that policy book's probably going to come back here and get a whole new book because it was invented at the beginning of the merger. There's obviously been a lot of things that have changed internally and with at the state level. So just making sure that we're up to date on all of those. But I think overall very well. Kareem was very pleased. I think it's kudos to the fiscal team and everybody that's worked on that. The other thing that actually came through that we're also proud of, it happened here just this week, actually, after he sent the report out, is the Ohio Department of Health did a COVID desk audit on all of that COVID money that you can see listed there. And I know Chelsea was sweating it because there was a lot of documentation we had to pull. I mean, there was piles of papers in her office, and it was very.
Was the desk audit announced or unannounced? I mean,
They're unannounced, so they just call you and say, we're gonna do a desk audit, this is what we're auditing, and you have to start pulling the files. They'll give you a timeline, to submit everything. But the best part here is that it says there were no exceptions noted, so we're excited about that.
Lindsay, that policy you were talking about, is that in reference to this compliance to CFR Part 200? And then do we have a timeline when that has to be completed?
Just as long as it's up to date by the next audit,
Oh,
because
okay.
so they did that before, they'll always kind of know, we've noted these in previous audits, so just good practices, obviously you don't
Sure.
want it to show up again.
Sure.
good job on keeping it organized and then getting it in. There was a lot of stuff.
And
And COVID was a little more than chaotic.
Yep.
Department and every business and organization.
And a big switch has been, we've had to go from, instead of every other year being audited, to being audited every year now. So that's been kind of an extra switch up, it's just an extra.
Will that continue?
Depends on if we expend $750,000, then yes, it will continue. So that's something that as we come into this fourth quarter, we're closely monitoring, because then we have to reach back out and let the state auditor know that we're gonna need to be on the audit schedule again.
Okay.
Not it with you?
That's
Yep.
all I need.
Okay. 3.2, Dr. Coase.
Well, let's just talk a little bit about COVID. Our rates have gone down in the community. Just got these yesterday. Our rate's 179 cases per 100,000. So what's being looked at from a standpoint of are we high, low, or wherever is related to that rate, and I'll come back to this. And then what percentage are testing positive of all of the tests that we do, and we're at 14%. Nate and I talked earlier this morning about something else, and said that's about as low as what we've been. And then from the third thing that's looked at is the number of hospitalizations. Yesterday we had 7 patients in the hospital. 6 of those were in because they came in with COVID symptoms. We may have talked about that last time. We had anybody that comes into the hospital, we do a COVID test, and mostly to make sure we isolate, et cetera. And one of those patients was admitted that way. We don't have anybody on ventilators, and we haven't been seeing a lot of cases, but I would say 5 to 10 would be pretty much normal what's been going on for the last month or so.
Just question, why are they in? Is it other medical problems, or they're sicker than average, or?
The ones that come in that don't have COVID?
Well, yeah, I mean.
Yeah. Oh, the ones that, well, even the ones with COVID. Yeah. Usually the 2 biggest criteria that are being used are they really short of breath, and what's their oxygen saturation? And then do they have comorbidities? But in general, Mike, it's related to comorbidities.
Okay.
The people that we're seeing now, they're not in general as sick as certainly what they were 2 years ago as to what's going on. The Omicron seems to be just what people are seeing out in the community, not quite as sick, but not feeling real good. Somewhat more of a influenza, achy, temperature. The 2 things, and I was going to say something about treatment. Well, Does that kind of answer your
Yeah,
question?
yeah.
Yeah, because it's a good.
The other question I had, are these people entering through the emergency room?
Yes, almost all of them. Some of them could be referred from a doctor's office. Doctor's offices are still doing, it depends on the office, still doing a lot of telemedicine if you think you have COVID. One of the problems with the data, BJ pointed that out last, and I think it's true. I don't know this data. I don't want to see it as any good. What's there is accurate, but I know of 4 people in the last 2 days that we don't have any reports on that were positive for COVID.
Well, that's why I asked.
Yeah.
Because they tested at home.
Probably 10 people that.
Yeah, because you don't need to turn it in. It's not reportable to the health department. And so we really don't know. That WHO, World Health Organization, they came out, and this is, I don't want to go into a lot of detail, but they came out that maybe we're getting to the end of the pandemic by their definition. So there's the number of cases that have gone down. There's been 6.5 million cases like that, or deaths, 650 million cases across the world. So, you know, what the data, but we're seeing decreases of percentages of what's been before. So directionally, and I don't know what their definition is going to be, pandemic is over. We are at the hospital, and I think the healthcare system and all of us, this is just, this is how we just take care of people. If you got COVID, we treat you, and if you don't, if you got pneumonia, you got something else, and it's not as big of a issue certainly as what it was before. As far as treatment, Pavlovid is the drug of choice. It's outpatient. It's, as far as I know, still being covered by Medicare. It doesn't cost anything for people to get on it. Recommendations are for those above 65 and high risk. High risk are the same things we've had before. I would say diabetes is one, but certainly if you have asthma or you have underlying conditions. It's not controversial. Nobody, back to kind of your question, Mike, is should we be treating everyone? Why not? And you get into resistance to the viral agent and the infectious disease people in general. New England Journal had a big article about it a week ago, feel that just stick with the high risk. But if you've got somebody that's pretty sick, within 5 days, if you get started on it, it's a 5-day course. Side effects are fairly minimal. You don't like the taste of it or you get nauseated, and that's not in everyone. And then there's a little concern about rebound. This is what the president was on, Fauci was on, and they then got symptoms back after their 5 days. But nobody's recommended giving it longer than 5 days. It seems to be that's as effective. Certainly the data, all of the research that was done, that would be the best way to give it. One of the
Would there be any recommendation for another round?
nobody is recommending that unless you're really sick, and then you're probably going to get into the hospital.
Yeah.
We have not had that happen here that I'm aware of, but people have had. One of the, where I have it's not a hard time, is people, they'll take it for 5 days and they may need to, I had to talk to somebody last night about that, and her test is still positive. Okay, well, she's getting better. About everyone is saying with those kind of things, don't worry about the test. It's an antigen test. The test may be picking up dead antigen. I mean, it's that kind of a test. But if somebody continues to have problems, that's when we're getting a chest x-ray. We're making sure there isn't something else going on. It's not, and again, I think the Abbott test is good, but when you say it's 95%, well, 5 out of 100 are going to have something either negative or positivity kind of rate. But Pavlovid is being used. I think that covered. Oh, I do want to say something about the booster, and I think that may come up later if you have any questions about what we have here. Is that you still need to get your primary series. The booster that is now being given is the bivalent that has come out. It's a little bit, Shannon and I were talking before, we don't have really good instructions as to what everybody agrees to be being said, but basically the way I understand would be a booster for, again, those at high risk should be getting it now if it's been 2 months from when you had your last booster or you were sick. And then the rest of the public, it's going to be available or going to be recommended in October. So my assumption is we just don't have enough vaccine to be vaccinating everybody to start with, but nobody's really come out and said that. And you probably have read that the general recommendation, CDC, and this is, I don't want to say controversial, it's just as it's scientific, is that there's going to be a recommendation that you get influenza and you get the booster on a yearly basis. I don't know whether that will change or not, whether it will be a year. But I think it wasn't so much it was a political decision to do that, it was to reduce some confusion. Because I have to say, I get confused. I can't figure out exactly what is being said. So if everybody in October, just assume you're going to get a booster shot next year after we get through this year. We'll see. The assumption I think that people are making is we're not going to see as much in the hospital. We're not going to have the outbreak. We didn't think we were going to have it last year, but we did. I'm not positive that that's not true because I think there's still a lot of people getting sick, but they're not coming back. They're not in the emergency room. They're not getting admitted. So what's our data going to be? So that would be, Shannon, is there anything else from COVID? We cover all this. Does anybody have any questions about that? She can tell you about what we have here, what's going to be available.
Are you starting to see the regular flu yet?
No, we haven't seen any yet. We're going to still.
Isn't it predicted that maybe?
But there's pretty good supposition that this could be a bad flu season. Partly, again, going back to the theory, there just hasn't been much immunity in the last 2 or 3 years. People have not had it, and how much is natural immunity, how much of it is getting the flu, and then we don't know whether we picked the right, what's the N1 and what's going to be. So we're going to be recommending people probably wear masks and wash their hands and the usual kind of thing. I don't know, Shannon, is there anything you wanted to add to?
Sure, I can go over what we have. I'll just do that now. So we in-house have Moderna and Pfizer. We'll start those clinics. We just received that vaccine, so we will start offering that to the public on Monday. We're going to have walk-in clinics, and once we have our flu vaccine, they will coincide together Mondays and Fridays, 9 to 11:30, 1 to 3:30. Those will be walk-in clinics, and then if someone can't make that, by all means, if they stop in and we can serve them, we will, or make an appointment for them. We do have both Moderna and Pfizer. Moderna seems to be a little bit more limited than what Pfizer is. We were only able to receive 100 doses of Moderna, whereas Pfizer we have 300, and I believe we put another order in for 300. We don't have those yet, but Moderna is not even available to order more of right now. So we're starting to get some of our flu vaccine in. We do not have it all yet, but there's no contradictions that they're saying, you can't receive both at one time. So like Dr. Coase said, we'll probably encourage people and ask them while they're here getting one or the other if they'd like the other. As far as the bivalent, it is approved for 12 and over. Pfizer's for 12 and over. Moderna is for 18 and over. There's still multi-dose vials, so we're still drawing up, multiple doses for a vial. Under 12 they can still get a booster, but it will be the monovalent. Otherwise, that monovalent is only for primary series and boosters for children under 11. What else? I feel like I'm missing something. We do have the Novavax as well, which is right now only approved for primary series. So the big thing is a lot of the questions are, when can I get my booster? 2 months. 2 months after they've completed their primary series, or 2 months after their last booster, regardless if that was their first booster or their 4th or 5th booster. 2 months. So that's they have made that a little bit more simple for us to follow this time around. But like Dr. Coase said, there's been talk of just encouraging the elderly and underlying conditions to get it, but there's no standing order necessarily to say you have to have X, Y, and Z in order for us to give this. If I come up and I say I have underlying conditions and I'm at risk, we're going to give it to you. There's nothing for us to really strictly go by. So,
what about timeline after you've had COVID?
So they are still encouraging to kind of work that out with your primary care physician, but it's still pretty much stating if you are fully recovered and you're feeling well, you can get it. But that's kind of, I think that most of them are recommending at least a month after you've had it. I know for a while there, it's still the 90 days, but a lot of it now is if you're fully recovered and you're feeling well, about 30 days after you've had it.
Part of that was because of availability. We didn't know how much they were gonna be. Well, you should have immunity compared to somebody that didn't, and that's why it's continued.
I read an article that recommended 2 to 3 months.
Yeah.
For better immunity.
Yeah, and I think you can, yeah, but there isn't any really good data one way or the other about what's been collected. It makes sense to wait a little bit because you should have got your own immunity.
Sure.
A couple things, the bivalent doesn't mean it's got influenza in it. That's one question I've had a lot of people ask me, not about necessarily bivalent. Why don't you just put these 2 shots together? Well, somebody may decide to do that. I'll probably have to do some research. I don't know that it's a good idea because I hope and there's going to be people that take influenza that didn't want to take COVID. And so if the 2 are put together, then okay, then I'm not getting either one. That's my opinion. That's not, I don't think, looked at. But the bivalent means that it's got the old in it, and then half of it is the new Omicron B4, B5. So you're getting both. And that's the reason that they took away the old booster because it was only for the old. And this is, and that's the only recommendation. That's the only thing that we're given.
Dr. Coase, I actually have a question. Sorry, didn't mean to interrupt you. Go ahead.
No, I was just going to ask about the timing of the COVID booster and the flu shot.
You can receive them at the same time. Yep. So there's no contradictions, even with any vaccine right now. I mean, even if a child comes through and they're getting their school vaccine, we can go ahead and give them that.
However, I'm gonna wait because they don't know. It's never been done before.
That's true. That's true.
I'm serious, because they still aren't quite sure what's gonna happen with all this mRNA running through our systems. It's getting boosted. And it's probably okay. But to be perfectly honest, nobody knows for sure. So I'm gonna wait.
No, and that it really makes good sense. The reason it's recommended is so you get to somebody and you get both of them.
Probably
So
get it done.
that you're going to get it done.
That's
Exactly.
the opportunity.
Versus, I think that makes
Because
sense.
the conventional wisdom previously had been about the flu, wait a little longer to get your flu shot, I guess.
You mean timing as time of the year?
Yeah,
Yeah, a lot of people will be getting flu shots now. If you look at it, it theoretically works about 6 months. And so if waiting, and we don't give them to the hospital until at least into October. I think it's going to be the 15th. I don't know if I've heard for sure, Karen, this year, but that was, so it's going to get you through March, which is, again, people are going to be outside more, and so you don't have as much influenza. But we've had influenzas in November, December, where it was the worst. I think about the worst we ever had was around Christmas time that one year. And then we've also seen it later into March and April when.
The trends have been, when I used to keep records in the ER, the trends were always February was a spike month.
Yeah.
So you want to be protected at least through February.
Right.
for the flu.
Yeah, the flu in the past.
The other thing that I get questioned about, if you've been taking Moderna, can you get Pfizer? Again, there's not, Jan and I talked, there's no directive saying you should or shouldn't. My personal opinion after listening to this last week, I think I've always gotten Pfizer. I think I'm going to get Moderna just because it's made a little different. It's got a little bit of what Mike said about, well, different the product, et cetera. Well, let's attack the immune system as much as we can by trying to rev up your immune system. Maybe that'd help a little bit. I don't think it makes that much difference. There's no data out there to say one way or the other, but people are asking, can I get one or the other?
It is approved for 18 and over to mix,
Yeah.
For children, it is not approved for them. They have to get the same one just because that's the way the study was done. My question for you, Dr. Coase, and maybe it's just because that's what the study and the research was done with the bivalent vaccine having, you know, both the Omicron and the original virus in it, what is their reasoning on why they want them to have that primary series first then versus the bivalent? Like if I've never received it, my question would be, well, I want protection from that Omicron as well. Do you know?
I think it's just because there was not any, just what you said, research to be, anybody has just found people only to get, let's say, the newer Omicron. And so they've stayed with that from the FDA standpoint. That'd be my understanding. Well, we've probably taken care of COVID here. If anybody gets any questions. I did want to let you know about monkeypox. We haven't seen any cases. Again, talking to Nate and talking to an infectious disease doctor from Toledo, it looks like the number of cases is going down nationally. We've identified the groups and et cetera. So questions on that. The only other thing that I wanted to say something about was the community health needs. I mentioned that last month. We had our first meeting, and we're in the, and then we had several people around this table participating in that, so you may have some comments if you want to. We're in the process of organization. Kareem and several of the other agencies have been getting more data, so we're trying to make sure that we've got a good synopsis or consensus across the community as to what the needs are, and we've already started to look about prioritizing chronic diseases. Diabetes is a big thing with our continuous glucose monitoring, and we're piloting that as a community. I'm sure that's going to be something that's seen, and then how we respond to the behavioral health. I mean, what are the issues out there? Suicides, the kinds of things that have happened since COVID, et cetera. So I think that process is going pretty well. The opioid task force, which Gary and I are both on, had in conjunction with the whole Be Healthy Now, had 2 open forums for issues related to addiction. Families or people coming in for feedback. John Malakis chaired that, and we will be getting some feedback from that that'll come back through our committees as to what we need to do. Other than that, I don't have anything. Bill?
With the back to diabetes, as I understand it, Dr. Grace is approaching insurance companies about the monitors, or how does that fit into anything the health department would do?
Yes. So at a high level, Tom's theory, which makes good sense, if and you may have heard some of this, but if someone has feedback instantaneously or real time about what their blood sugars are doing, they are going to take better care of themselves. That would be the supposition, which makes pretty good sense. And he's also done that with several people, whether they're pre-diabetic, whether they have diabetes themselves, whether they're on insulin or if they're not on insulin. Insurance has in general only been covering it if you're a insulin-dependent diabetic. And so and he's really gotten into this. We're going to have to get him here to talk about once he gets some more of his data and things back. But he started to do this on some of these individuals that were, let's say, diabetics on pills or just trying to maintain their weight or trying to reduce weight, more exercise and things like that. So, and Laura can comment on this. She's been working on this too, not just with the mobile clinic, but we've got about 100 people that are signed up now. There's another 50. You may have some more current data from when we talked last Friday that we're making callbacks, and we have now started to really encourage our medical staff to do it. I think the paperwork has probably been more than what we thought it was going to be. I'm just keeping track of people, because we got to give feedback to the primary care doctor. We're expecting them then to go over this data. If you were diabetic when you came in, well, here's what your blood sugars are showing. A lot of people are picking this up pretty quickly. I know a couple of people have been on and they can't believe, oh, I don't know whether I should eat this or not, or This is, that sort of thing. So that's the high level idea. He got a grant for, we could get up to 1,500 people, but we started out, we want to get 200 and get good data. And then I think there's enough statistical analysis around this that really we'll be able to, it's not so much publish, but to be able to say, this really does make good sense, and you ought to cover it as an insurance company because it's going to be in your benefit. You're going to reduce the number of medications, the morbidity of diabetes, and all of those kind of things. I think it's really pretty exciting because it's a community-based sort of thing.
I mean, it just seems, why wouldn't they want to think that way?
Well, I've never been on an insurance company, but theirs is ROI, cost benefit, and I think we prove that's what he's really out to say, that this is going to make a difference, and your cost as an insurance company are going to go down. So, Bill, completely agree with you. This technology is something else. I mean, it really, we used to have my partner, 7 times a day, you were sticking your finger, blood sugar, colon, that kind of stuff.
Yeah.
Hopewell, people didn't. I mean, I don't like having my fingers stuck once to give blood. And so this is just feedback, and people, you have any?
Yeah, I was gonna say, can I interject as well?
Sure,
Is that okay?
yeah.
So the mobile health clinics, I'm Laura Reinhardt. So part of the mobile health is we're helping out with this project for continuous glucose monitoring. So the actual manufacturer of this continuous glucose monitor that we're using is called Dexcom. So through Dexcom, we're doing this study, also with the University of Findlay as well. So like Dr. Coase said, we have 100 participants so far. So that was like amazing to hit that benchmark, first of all. So now we're into getting 3-month follow-ups. So we're still getting people onto the system, like new startups, but we're getting people back now. And the feedback we've gotten so far has been phenomenal. Specifically, one patient exactly was a hemoglobin of 11.2 or 11.7 right at the beginning of the study. So since we brought them back for the 3-month follow-up, their hemoglobin A1C is 8.2. So like seeing that dramatically decrease. Yes. So, and then also we're getting feedback of real-time monitoring. So one patient called Elisa, who's the medical assistant that's doing all of the really hard work into all of this. He called her and he was in the drive-thru at McDonald's. And he goes, Elisa, I'm at McDonald's. And my continuous glucose monitor, says my glucose is, I forget what she said, but I am debating on if I should get that large sweet tea that I love. And she goes, what are you gonna do? I'm gonna get a water. So right there is real-time proof of how great this is for our type 2 diabetics. And like Dr. Coase was saying, insurance companies traditionally do not cover continuous glucose monitoring for this type of patient. And with all of these new diabetic medications coming out, a lot of people aren't getting to insulin when they were getting to insulin earlier before, in my perception. I did a little primary care as well and stuff. So getting these monitoring systems covered for these patients are impossible. So doing this data, doing this, research study, I think is going to be very hopeful to help our community. And also this is part of our CHIP, the Community Health Improvement Plan, to help improve these diabetics outcomes overall, not just what their blood sugar is right now, but years down the road, seeing, not as many side effects, not as many problems going on down the road. So it's a really great study. So we're still enrolling people, and like you said, the outreach, we're getting more people, more physicians to, send their patients our way. We're even getting patients from Tiffin, Astoria area, not just Blanchard Valley, system. We're getting them from ProMedica, we're getting them from Gnomes. So yeah, great outreach. Yeah.
Does it have to be physician referral?
Physician or a nurse practitioner, primary care referral is who we take ones.
And you need about, 50 more, did you say?
Yeah.
The goal is 200, right?
But we'd be glad to get as many, but we'd like to get 200 to just have the number in. The reason is so that there's someone to go over the data with.
Sure.
And so from the mobile clinic, she's seeing individuals that may not have primary care.
Yeah.
So we've worked out a plan with Kaufman so that there's somebody that will be for whatever the reason.
Yeah.
So Laura can refer?
Yes, yeah, so as a nurse practitioner, I can refer to whomever I see fit. Like with, kind of sliding into the mobile health role, in this discussion is if we're seeing patients who don't have a primary care physician, referring them over, like Dr. Coach said, to Kaufman or whoever is like geographically good for them. Over at the fair, we saw a couple patients who didn't have primary care, who we were looking up things to say, hey, you need to call up this person, they're in your area, to get linked up with primary care, because it has to be ran through some sort of other clinician who is going to be monitoring and looking at the data, looking at the glucose, looking at what medications they're on to adjust accordingly. Because as these glucose levels are dropping, they shouldn't be on as much meds, depending on what the medication classes are. So we really want to make sure it's safe, and also that we're not just getting our data for our study, but we're actually improving these patients,
And that goes back to your question, Bill. I mean, so these new diabetic medicines are unbelievably expensive, and so is insulin.
Yeah.
So if you can reduce that from an insurance standpoint, or whoever's paying for it, that is positive. And a drop of hemoglobin A1C from 11 to 10, I've heard, let's say that may save 5 years of your life, and it may be even more than that if you can sustain that and keeping it down. So dropping it theoretically, and the diabetic is very expensive to take care of besides medications because of all the complications they get. I think eyes are one of the big ones, vascular
Kidneys,
kinds of
dialysis.
people on dialysis, and then heart. So all of those things are just real public health things that we're trying to reduce. Brian, I think you may have a question.
I've been on a monitor for a few years, and it helped tremendously. I haven't been in the sixes with A1C since.
Yeah.
And I was never high. I never even got to 8, but still going from 7.5 to 6.6 or some number is a massive improvement.
And one thing you say to patients is, if you're like that, you're normal. I mean, people live the same life, if you've got yourself well controlled, keep your blood sugar. That's, again, if you don't, Tom Grace is a diabetic since age 4, insulin dependent. And that's one reason why he's passionate, and he's been well trained, and the diabetologist that took care of him. But the data is there's lots of people do well if you keep your blood sugar controlled.
The other thing we're studying also is not just A1C during this study, but we're also studying like weight variances, also blood pressure, going forward throughout the study. And then we're also doing like a survey on mental health and referring to what does poking your finger every single day, what does that, and how does that impact your life and your quality of life, versus what we did the initial study at the beginning, and then we're going to do it throughout the study to see like how the continuous glucose monitoring helped their well-being, helped their overall quality of life. Because like we were talking, poking your finger 7 times a day, especially for active people, going out, eating, at different restaurants and things, you gotta get your stuff out and poke your fingers, that's very impactful on quality of life and also compliance. People don't want to get their stuff out, so I'm not gonna check my blood sugar. Where this is right there, real time. You can look at your smartphone, or if your smartphone doesn't work with the program, they give you a receiver which looks like another cell phone, and you just carry it around. You look at it. Oh, my blood sugar is this. I'm not gonna, do this, or maybe I can have this time.
Okay, my sweet tea.
Yeah, exactly. Maybe half cut this time. Yeah.
So do we expect glucose monitors in Happy Meals?
No. Hopefully we can ixnay the Happy Meal if you ask me.
An attorney may not be able to say things like that.
The health professional can.
It's exciting.
Yeah, very exciting stuff. Am I allowed to talk about the mobile health now? Am I
Yep.
next on the docket?
Hand off,
Is that okay?
So we're rapidly moving from.
I'm sorry.
3.3.
You get me talking, I'll talk forever. Everybody knows about that. So I'm Laura, the nurse practitioner with the Mobile Health Clinic. So I'm really excited to get started. So this month will be my first full-time month. So I started full-time in the beginning of the month starting with the fair. So the fair for the health department and the mobile clinic specifically was very exciting. We got a lot of touches. I'm approximating about 600 people stopped by, got information. We gave them some goodies. We were passing out, stuff for like kids, geared towards kids, like bubbles and pencils and a little bit of candy. But we got a lot of health information out to the public. And And then also, we were talking about, screening people. So we had about 35, 34 people come in and want point of care testing. So with the mobile clinic, they have the capabilities of doing blood sugar and hemoglobin A1C and also cholesterol. So we had patients come in. The majority didn't have any kind of issues, but there were some, catches where I had somebody come in with a hemoglobin A1C of 10. I'm like, oh, what are you doing about this? And he does follow his primary care in the area. He does say basically that he's non-compliant, and this doctor has been talking to him. So I really tried my best to hook him up with our, continuous glucose monitoring system. He did not want anything to do with it. But, I tried and I gave him information about it. So if he wanted to, he could, but you can take a horse to water, but you can't make it drink, as we all know. But saw a lot of good catches and heard a lot of good and positive information. Saw some township trustees out there as well, and talking to them about how the mobile clinic can come out and help them and, get some things set up. So really this month has kind of been spent networking for myself, as I'm new to this role and new to public health and maybe a new face to a lot of Hancock County. So going forward, we have a couple of events coming up. We're going to go to some parades. We're also linking with the Finley Mobile, the Bookmobile, doing some kind of taking the mobile health clinic out with their celebrations coming up in October. We're going to partner with 50 North for their senior wellness fair coming up October 1st. So yeah, lots of good, exciting things on the horizon for the mobile health clinic. Also, we're looking to get into the city mission more often. I was part-time over the summer, trying to help out as much as I could. So I could only go out there like once a week. But now since I'm full-time, I think we're going to ramp up those services because that's much needed. Also going to reach out to Hope House to see what we can do for them as well. Kind of on the horizon. So yeah, and then be involved with the CHIP program with the community health assessment. So that's kind of what's going on in the mobile neck of the woods.
How about the county jail?
The county jail, I have not thought about that, but I am not opposed to helping out in any way I could. Usually I know county jails typically have their own kind of medical, I believe they usually have a nurse and like some sort of ordering clinician over top of them, whether that's a nurse practitioner or a physician. And I think they usually contract with like an outside agency, if I understand. I definitely don't know all the ins and outs, but from what I kind of remember, but I would be happy to contact them, see how we can help. And even their employees, I mean, they're citizens of Hancock County too, so they're often left, taking care of others and not taking care of themselves, So, yeah, I'll make sure to reach out to them. Any other questions that I can help with?
Great.
Perfect, thank you. Thank you for the time.
How about Veterans Commission?
Yes, they're on my list to start talking to see how we can help them.
I think one of the things that she's trying to be doing is how we incorporate behavioral health into this, the social determinants kind of thing. But it was brought up about diabetes. We are specifically surveying that people feel better about themselves, and diabetics may have more problems because of the COVID and what happened in trying to get referrals and things like that. So we're using diabetes as kind of a pilot, the holistic across the whole thing. That's been going really well.
All right. And we're at 3.4, Chad. Planning.
Well, obviously you can see as our report typically is, it's pretty comprehensive. So I'm just going to give a couple of highlights. Lindsay talked about the grants that are upcoming and that we're continuing to work through. We still haven't heard on our harm reduction IN24, what that's going to look like. We've been in contact with the state. That is one that we've used for funding our peer support position. We expect it to most likely be a 9-month. It's going to pick up in probably January and go through the end of September. So we're kind of looking at that, and hopefully we'll hear pretty soon on that. The SOAR 3.0, we're using right now, utilizing money from the state opioid response, which is the state funds for our local response, and we have that's how we're funding Brittany's position right now. We're also utilizing that, and we're utilizing it in 23, but we're waiting on the additional award to come out from Adamus. They're the ones that are the funding source. So we're gonna be hopefully getting that information as well, most likely October, November, we'll know what that amount looks like. We are most likely gonna be meeting with Dr. Flaherty, some of you know who he is, he's kind of a national expert on overdose response in communities. They're gonna be having a meeting with him next week, but we're actually gonna get a private audience with him for about 30 to 45 minutes next Thursday, just to kind of talk to him a little bit on a couple of things that we're working through is getting our peer supports recognized kind of on the same level as many medical or other type of experts, because those people have lived experience, and since we're working with individuals who have an addiction, making sure that their insight is recognized just as much as a clinician or other individual, and how we best do that. The other thing is involving law enforcement. We're still having a challenge right now with some local law enforcement agencies getting on board with seeing value in our program, because again, I think probably just goes back to the training that they have received. Is we're here to enforce the law, still against the law to have drugs and paraphernalia and all that on you, so they see those individuals as criminals still. And so we're going to ask him and maybe try to pick his brain a little bit on how we best approach that to get buy-in. And it may just be a philosophical thing that we'll have to continue to work towards changing. One of the interesting things too that you may have seen in the report is we've been distributing the LOX boxes. So we received some of the funding from that SOAR 2.0 from Adamus, and we purchased 22 of those. We're planning to purchase more, but what it essentially is, it's like an AED. So if you see an AED, it's got typically all the supplies that goes with that. But these are being located at places that we have seen activity, or even in some of the treatment centers and residential centers that we have. But we're also starting to target some of in the smaller communities, maybe little hubs like gas stations or community centers that may be able to have that available. And then what we'll do is we'll work with them to make sure that that supply is maintained. If they use the kits, they expire, we'll go back out and change them out. But the expectation is that our peer supports will go out monthly or maybe quarterly to check those as they need to. And they just have those touch points. How's everything going? Are you seeing any activity? Are people asking questions? So just something like that. But I think it's an interesting concept and practice that we're putting in place.
You know the cost of those boxes?
They're about $300 a piece. And it's nice because because they come with the supplies, and we've been able to leverage money from not only the service program portion of the integrated naloxone grant that we received to buy additional naloxone, but we also used some of the SOAR 2.0 money to purchase that, because we had a short window to spend it and we wanted to go ahead and maximize that. So we've been able to purchase probably close to 470 additional kits, and then we'll be supplying them.
So the box, like the normal, has 2 doses in it, I think, right here in the box.
Yep, and it'll be the same. So we'll have about the same, and it'll also have like a CPR mask, and additional instructions on how to use that. It won't be locked or anything like that. It'll just be accessible. But it's been nice because they've already been distributing several, like Focus has one, and some of the other places here locally have already been have those. So they're just getting those installed. But it's, like I said, it's a nice practice that we're putting in place.
Where would they normally be placed?
So when we get them, so for example, like Basu Point, which is an inpatient residential center, they actually have they have one. They've already received it. Like I said, Focus. Some of the places that on its face you would expect some place to have. So those places where individuals are going already, we're getting those to them. But some of the more non-traditional places, like I said, if you go into Macomb or you go to Arcadia, think about maybe the gas stations or the little restaurants that might be there, churches even, because there have been some churches that we're trying to reach out to as well. I know there used to be a ministerial council that it kind of disbanded, and it's kind of, so we're trying to.
Well, my question is.
Oh, I'm sorry.
It's really, would they be located near AEDs?
Yeah, in theory. I mean, it makes sense if everybody knows that that's where I go for,
Yeah.
you know, the AED, then you co-locate that, yeah, because the mall has the same thing. We purchased an AED for them back in 2014 with the Medical Reserve Corps funding. We purchased that at the guest services. So in all likelihood, if we wanted to put a Nalox box there, we could put one there, and it would all be in the same location.
Yeah. Makes sense.
Health education, Jess has been continues to be pretty busy with, you know, car seat education. She actually helped out Williams County. I'm not sure if you saw that in the report, but she went up there. They had a car seat event where they had 90 seat checks already scheduled, and so she went up, and they only had one tech in the health department. So she went up to help with them, which was huge. But again, we continue to see a high misuse rate, you know, 60% for August, and that hovers always usually about 5%. I was actually at the hospital the other day doing a car seat check for new parent, and you know they have both belts installed, and they have the lower anchors and the seat belt. It's kind of like the more is better concept, but you know, you go in and you speak with them and you educate them on, you know, this is the best practice, and you know, and they really are appreciative of that. So that's a great opportunity. And then Jess was busy pretty much the entire week at the fair with the Safe Communities grant that she has, that we've also received again for this upcoming year, just to let people know the dangers of distracted driving as well as impaired driving. And we usually take the impaired goggles, the fatal vision goggles. We actually did that at the National Night Out back in August, and it was a success. People always want to go over and try it out. And it's always entertaining to watch adults put them on and kids put them on, and it usually draws more people over. Kind of like actually, I was going to say the money wheel, but the prize wheel that they had at the fair, it draws people in. So that was really good. Epi, we already kind of talked about the COVID. Hannah, continues to make contact with individuals, positive cases on that. Our MRC is starting to ramp back up a little bit. We actually have been involved with the University of Findlay. We're starting to do work with them at their health center on testing. So our medical volunteers are out there helping their medical staff with their testing. And then we're hopefully going to start up our MRC training here in October. We've been trying to work with Hanco on getting rapid triage and stop the bleed training set up with those volunteers so that they can stay involved that way. I know we're still kind of working through, depending on what our clinic will look like. I know I've been talking with Shannon too on will we start utilizing the MRC volunteers for our upcoming clinics, and that remains to be seen. We'll see what the uptake is on the vaccine itself. And as you probably saw with the last, I think Cheryl, she's super involved with message, and these are all the outreach that she has been doing, whether it's been in person or through the multimedia platforms that we utilize. It's been nice to have her continue to manage our messaging with our different programs. That's all I have, unless there's any other questions.
I won't talk.
Go ahead, Jay.
Okay, I won't talk too long since we already went over the COVID booster and whatnot. I will just take note on clinic. If you look through those numbers, comparing from numbers before in the past, one thing that you'll probably notice, and I think we've talked about before, we are getting those patients in, but again, they're getting just the required vaccine. So what stuck out to me this month was, okay, we have the same amount of number of patients as we did before, but why are our doses down so much? Like, we don't have a new combination vaccine, but again, talking to the girls, it's when they're coming through, they're like, I just want what's required. However, we are starting to see numbers ticking back up that she said they're coming back now later in the fall and saying, I do want this now. So hopefully it'll all even out. Hopefully our education and getting out in the schools will be beneficial. Jane and I have been going out to do the school nursing part of it, and we heard wonderful feedback of having the mobile and having the clinic staff out there at their open houses to give vaccines right there before school starts and when they're getting their schedules and, you know, meet the teacher and that. So I think we will most definitely do that again and try to get in with more of the schools as well. You know, access and making it easy, we'll get those ones that maybe normally wouldn't get it till December being hound. So that's a good thing. CMH program, not a whole lot new there. Actually, even the numbers, we don't even have our payment in for the month there that is up, skyrocketed from years before. So it's actually higher that we just got paid, but at the time we didn't have it, so I didn't include it in there. But things are going really well there. Alexa's been able to go out with some of the different outreach programs and just kind of market that program as well. It's just a program that here locally a lot of people aren't aware of. So that's all good things. I did include in the packet that senior fair that Lauren had touched on as well with the 50 North. So looks like they're going to have a lot of things there. We will be there in addition to the mobile clinic providing flu and the COVID. So hopefully we'll be able to, if we have vaccine left over by then, I should say. I don't know what to anticipate. We're preparing for a lot come Monday. We've been receiving a ton of calls for the booster, and even after putting it out there, like, do you have it yet? Do you have it yet? So we're prepared internally. So I always say it's better to be prepared than not. And there was something else I was going to touch on. As far as flu clinics, we have a handful. They'll pretty much be the ones we've done in the past, but I will get that flyer. I'll send that out once I have a comprehensive flyer. I'll send that out to all of you guys to share and to have, but I don't have one comprehensive flyer yet, but we will. Our first one will be 50 North on October 1st, and most of them are within those first 2 weeks of October. 50 North, Marion Township, Arlington, Good Hope Church, Macomb Library. We'll have one here as a drive-through as well. I said that one. So I'll get you guys that flyer, and then we'll have our ones here at the health department as well. But those ones will be after hours to help with families and working people as well. So otherwise, I don't think there's a whole lot new unless you guys have questions for me.
Questions, Alexa?
So Help Me Grow is kind of breathing a sigh of relief. We had a really busy end of the month with the fair. If you guys had a chance to stop by, it turned out really great. We got a lot of awesome feedback from the relaxation station. Plans did have to change a little bit. So initially we had planned to set up in the 2 kitchen areas with one separate area for lactation, one separate area for baby changing. One slight detail was that the veterans committee or the veterans group had rented out the old Millstream building on Wednesday for an all-day event, and they were having a meal catered. So we ended up moving our station to that meeting room in the back where we had our board retreat last year, and it worked out better. So we had a couple areas set up for changing babies. We had some rockers in there that Dr. Coase helped us get a hold of. There was an area where kids could play. It was all air conditioned, so a lot of people just went in there to kind of relax and gather themselves before heading back out. We passed out a lot of information. We got a lot of positive comments. I did include a picture of it just in case you weren't able to attend or stop by. I know I saw Bill, I saw Nancy, so hopefully it will be an event that we can continue moving forward, but it turned out great, and it's a great building just because it does have that air-conditioned feature. So especially for new moms, that's really nice.
Are you going to do it again next year?
We're hoping to. You never know with fair leadership how that's going to pan out, but hopefully. I'm hoping that they received enough positive feedback that they'll want to continue the service. It was well used. I was in there several days, Wednesday, Thursday, Saturday, Sunday, and there was at least 20 families in there at one time. So it was great, and hopefully it's something we can build on. We've talked about maybe offering like bottled water or more agencies and resources. We kind of started with a small team, but it was great. So we were really pleased with that. In addition to hosting the relaxation station, we also did a group at the fair because they had free admission that Thursday. So we did a scavenger hunt. We used some of our pizza vouchers for refreshments, and we had 23 families that attended. So that was great for them to be able to enjoy that day out, not have to worry about admission to the fair, not have to worry about food.
We also had water, and then we introduced them to the animals so they could work on things like animal recognition, animal noises, that type of thing. So that was really fun. We will be taking a bit of a break as our next group won't be until the end of October because we'll focus on Halloween and trick-or-treat and costumes, that type of thing. So it'll be a good break for us to regroup and plan our next adventure. So next week I am going to Findlay Digital. We'll start up our moms group. We're thinking about renaming it something more inclusive because there are some dads that want to participate as well. So I'm working with Amber from Findlay Digital to get that process back up and going. I usually go out there once a month, so it will depend on how many moms, families they have interested, but I'll have more of an idea next week. We are planning a lot of outreach. Yesterday, we were able to go out to the big food distribution at the fairgrounds. That was a wonderful event. We ended up with 2 referrals. And there were a lot of people, not only from Hancock County at that food distribution, there was a lot of people from Wood County at that as well. So they'd set up a nice area where they had all kinds of agencies set up. So there was Hope House there, there was Head Start there, there was mental health services there. And what they did was they had a scorecard, and clients were encouraged to go around to each booth to get information in order to be entered into a raffle. So we got a lot of foot traffic there. They had a meal as well as the food distribution. So that was a great event. It was very eye-opening to see how many people take advantage of those food distributions, but it did result in 2 referrals. So as far as outreach goes, we are focusing on our Wood County population because that continues to struggle. We're still at only 3 slots filled. But I am working with our outreach specialists. We are assigned 1 outreach specialist. She works for the entire Northwest region, but she is putting together a baby fair in Fostoria. So that will be able to help 3 programs, Hancock, Wood, and Seneca. But we are right now just brainstorming what that looks like. I have a feeling it will mimic kind of what WIC does here in town, where they do a drive-through baby shower. So pregnant moms are invited to visit the different stations. More information on that as we get that planned. We do have the WIC baby shower. We also have an Arlington community baby shower put on by one of the churches. That will be a great opportunity. They have a food pantry there in town, and they have a lot of ministries. They do like a team breakfast and fun and games like after football games and basketball games. So we do have a few families in the Arlington area that will be nice for. I think that's all I have.
I just want to commend the health department for being present at the fair, because that really meant a lot. I did go to the fair. I didn't stay long enough to see Kareem in the dunk tank, but
That's on our plans for next.
Yes, yes. But yes, we did have a great turnout.
Yeah.
It was a good event.
It was a great event.
We had nice weather too, for the
Yeah.
most part.
Yeah.
One day it rained.
Yeah.
All right, 3.7, Lindsay, environmental.
I know my report wasn't very exciting. EH is kind of coming down off of the seasonal, the high peak. The fair was, quite exhausting, but we made it through there. We're also taking the small celebrations, and after 2 years, we finally were able to get our first round of food inspections completed at that 6-month mark. So we'll take in the small wins right now. Other thing, mosquito program is starting to it has wrapped up. We are going to do a kind of a year-end wrap-up, and at the next board meeting, Kurt will do a presentation of kind of like where it started and how it ended, just to bring that full circle. Last month I mentioned having conversations with Hardin County to take over the commercial plumbing down there. We have had that meeting. The contract is drawn up. I'm waiting on our legal to review it, and then it'll get shipped off to Hardin County for their legal, and then we just need to kind of confirm a date of when we're going to make that effective. The other thing, EH's involvement at the fair, we were kind of primarily there doing our job, but some of the staff also jumped in and helped with the wheel at the fair. It's a great opportunity to get our mosquito information out there. We have freebies through that grant that Parents are pretty happy with. The kids love the mosquito bracelets, and then we have wipes as well, so everybody likes that. The last thing that you can see kind of down the agenda a little bit, and it's in my notes, is Andrew Lehman, the gentleman that we had hired back in May. He is no longer with us, so currently evaluating that position and just seeing what things are going to look like moving forward. But for the time being, EH is in a good place, so we'll make it. We always do.
Are we needing another?
Yes, we need that position filled. There's a couple other opportunities that are coming along. Bowling Green State University, the environmental health program, or actually I think it's more of the health service thing, has reached out to Kareem about seeing if we can partnership to become kind of a teaching facility in cahoots, which would open us up to being able to get students out of that environmental health program so they can kind of shadow, see what's going on. Also maybe getting some social workers in here since we use those. EPIs, you know, so gonna have those conversations, see where that leads, and maybe there'll be opportunities that come out of that as well.
Here, all right, Craig, IT, health, and data.
Seat here too, so I'll keep it brief. I know it's gonna warm here, and I don't want to put you guys to sleep with all the fun IT information. Just an update on, I know I spoke a while about we're waiting to get our new copier, and the good news is we did get a copier in since that's been on back order since January. The bad news, we were going to incorporate like a badge reader, like we have the badges to get in to the different doors around here. We're going to be incorporating a badge reader into that printer, so that way since we do have a main central printing area, a lot of times people print off things and kind of forget about it, and if there's some HIPAA information, that can be a little bit of a problem. So we're going to incorporate a badge reader with that printer, so when they go up to the printer, they scan their badge and their documents they're waiting to print will print off for them. So make things a little secure. Unfortunately, the way it integrates and the way it's kind of explained, we also want to look at tracking especially for grants, being able to track who's printing what so we can charge them back to grants. Unfortunately, those two don't work too well together. So we're looking at some software to do a better job of integrating those two together. So I've been working on that. And also some of the other projects have wound down. I started focusing more in on some IT projects, continuing updating kind of our computer supply, updating the old computers, particularly working on some automation projects with the new computers, being able to set up the computers faster. In the past, when I'd get a new computer, it'd take me about half a day to install a new computer and get everything set up. But with the new mobile management system I have set up for computers, case in point, my computer died, I think the other weekend. I came in and my computer was totally dead and had this smell of burning electronics. So I knew it wasn't good. So, but I was able to get myself a new computer up and running within a couple hours. So, and even less than that. So, it's kind of helping me kind of go forward as doing updates, managing those centrally instead of me having going around and touch every computer. That's saving me a lot of time, saving me a lot of after hours work coming in during the weekend, and obviously saving flex time that the agency's going to have going to pay in and keeping that flex time down. So, and then also working at cybersecurity issues, just hardening our cybersecurity, particularly our backups. As we move away from HDIS, that's going to free up some equipment on the server side that I'm going to utilize to kind of harden our backup system and make it more cyber secure. So I'm excited as we're moving forward to do that. So that's all I have, I guess, unless you guys have any questions.
Information.
Yep. Thank you.
All right, Kareem's not here. Are you taking over this?
Yeah, it's just very
Email
quick.
us the info.
It's just very quick. I know Kareem wanted to reiterate the fair team and all the hard work, and he thought, when we first were told where we were gonna be set up, there was a lot of skepticism. We were a little concerned, were we gonna get the foot traffic, because we had all of those food vendors in front of us. But after the first day, it worked out. I mean, we were just right in the perfect flow of traffic. So I know Cheryl has reached out to the fair group, thanking them for that place, letting them know that we appreciated it, that we're interested in being back there again. Also, putting emphasis on those relaxation stations. We want to do that again, maybe adding some more components to that as well. Kareem has also put together an internal fair team. So we kind of came back together, all of us involved, did a hot wash, worked through the pros and the cons. And I believe Chad's team's going to then take the lead on that. Starting here in January, they'll get a team together and start kind of putting together the promotions portion of it. So I think we've got a better plan in place than we've ever had to make it even better. And I will tell you, Bill, that part of that was that dump tank. So,
Oh.
so we're working on that.
Well, I thought it was very creative that the health education booth was right next to the sheriff's office with those beer goggles.
Well, they partner on the grant that is used to do that funding.
Bill, the real question is, did you try the goggles?
For a friend, yes.
Did you?
And then just for the legislation update, those individuals are still on recess, so there's nothing active right now. I'm sure Kareem will have some updates though when he comes back next month.
All right, I guess we can talk about old business that we already spoke about a little bit, but.
Yes, so Andrew was on probation until September the 24th. So when we did a probationary review on September the 8th, we parted ways at that moment.
All right, 5 no CEUs offered today. Next meeting is October 21st at 7:30 a.m. Same place. Any other comments or questions or needs? We have a motion to adjourn.
So moved.
Second. And all in favor?
Aye.